in the next session, we're going to focus on all you need to know on electrosurgery. And this is obviously a hot topic in interventional cardiology. You cannot pass a significant meeting without some presentations or demonstrations of electrosurgery. But guess what? We have the Grandmaster of Electrosurgery himself joining us. So it's my great pleasure to invite Adam Greenbaum to the panel. And over the next hour, we'll explore the practical ins and outs of electrosurgery and how this exciting new technology has opened an avenue of new applications. Adam, thank you very much for joining the panel. And without further ado, it is my pleasure to give the floor to Mohamed and give us the overview of the applications of electrosurgery in 2026.
Yeah, thank you, Nicolas. And so my topic in the next few minutes is to give you an overview on a wide range of application for transcatheter electrosurgery. So first of all, what is transcatheter electrosurgery? Probably a majority of you know this, but just to simplify, it's a technique that is being used to traverse or cut tissue using alternating current, which we do typically in blood-filled spaces, and this is directed by guide wires and catheters. And importantly, to perform electrosurgery, that is to be able to traverse or cut tissue, you need continuous radiofrequency energy because the aim is to vaporize and therefore traverse or lacerate tissue. So you need continuous duty cycle radiofrequency, which is simply the yellow button on this electrosurgery pencil that you use in order to electrify your guide wire. So it's not the blue button, which would be the coagulation button, which gives you a pulsed form of radio frequency energy, but it is the yellow button. And a further important principle when you apply electrosurgical technique is that in order to successfully traverse or lacerate tissue, you need to optimize and concentrate the charge either on the tip of your guide wire or on your cutting surface. And to do this, you would need to insulate your guide wire. And the more you insulate, as you can see here on this graph, the more energy or charge you get at the tip of the wire or at your cutting surface. So yellow button and good insulation. There are like a couple of dedicated wires available. One of them is shown here, which is typically used for transeptal puncture, the VersaCross wire. But usually when we do or apply electrosurgical techniques that you will see during this and other sessions, we use non-dedicated devices, at least in Europe. There are a couple of dedicated tools that are, one of them is already being FDA approved in the United States, not in Europe yet, which is the so-called Telltale system. And there are a couple of others that are being developed. But I think the majority of us would use non-dedicated devices, which usually depend or simply depend on an 0.14 wire. So the clinical applications are multiple. You can see on this slide maybe the main indications: transcaval access, mitral or anterior mitral valve leaflet laceration, what we call lampoon, basilica, which is the same for the aortic valve, and sesame, which is a transcatheter myotomy. But you can also divide this or the applications into two main forms. You can use electrosurgical techniques to traverse tissue, which the typical example of it would be the transcaval access. And you can use it to lacerate or excise tissue. And the typical example for that would be leaflet modification, for example, of lampoon or basilica. And surprisingly, if you look into the literature and ask colleagues and friends, you will find multiple applications of transcatheter electrosurgery beyond what we may call now classical techniques. So it's classical because probably they've been there now for almost 10 years, or maybe more than 10 years. I think the very first publication of transcaval access of Adam Greenbaum was 2014. So here are a couple of examples. So you can use electrosurgery to obtain vascular access in the case of a transcaval access, and this is an application of electrosurgery to traverse tissue. You are traversing the IVC into the abdominal aorta in order to establish a connection between both vessels and be able to perform, for example, a transcatheter aortic valve replacement or other procedures that require large bore access in patients with peripheral arterial disease. So this is probably one of the oldest applications and a very classical one, and you will see a whole tutorial on that today. Probably the most common application is to use electrosurgery for aortic leaflet modification, and the typical example is basilica, where you use electrosurgery to traverse the aortic valve and then to cut the aortic valve using a cutting surface, what we call a flying V, and then implant a transcatheter valve and avoid coronary obstruction. So leaflet modification in this context is being done to avoid or prevent coronary obstruction. There's currently a modified technique, which we call unicorn, where you only traverse the leaflet, then dilate the leaflet with a balloon, and then usually implant a balloon expandable valve inside the leaflet, pushing the leaflet away from the coronary ostium at risk, and obliterating or encasing the leaflet on the opposite side of the coronary ostium. So this is unicorn or intraleaflet deployment. You can do, of course, the same thing for the anterior mitral leaflet to avoid LVOT obstruction. When you are planning a transcatheter mitral valve replacement, there are multiple phases of lampoon. You can do this retrogradely, antigradely. You can do it from the base to the tip or from the tip to the base. Probably the most common procedure is antigrade lampoon, which is a base to tip laceration. This is again puncturing the anterior mitral leaflet or traversing using electrosurgery and then using electrosurgery to lacerate the leaflet and avoid LVOT obstruction. So you can lacerate a mitral or tricuspid leaflet, but you can also liberate a mitral or tricuspid valve leaflet, what we call elastaclip. So in patients where clipping has not been successful and you want to implant a transcatheter valve, you can liberate the leaflet again using transcatheter electrosurgical technique, again using this cutting surface, which would facilitate afterwards, like in this case, the implantation of a transcatheter valve, in this case, in the tricuspid position, but this is something that can be done also in the mitral position. You will see a recorded case of SESAM, which is an exciting procedure where you can use electrosurgery in order to traverse the interventricular septum and then lacerate it to perform an electrosurgical myotomy, which can be done in patients with hypertrophic obstructive cardiomyopathy or preceding transcatheter mitral valve replacement, again, to avoid LVOT obstruction. And then there are a few of very exciting cases that have been done. Like you see in this case, transcatheter electrosurgery has been used to excise tumors. In this case, you use a snare and apply electrosurgical technique in order to electrify the snare and remove a cardiac tumor. It has been used in the coronary arteries, for example, for retrograde recanalization, one of the very old applications, actually, which some people call ECART. So to use electrosurgery in order to retrogradely recanalize an ostial RCE, such in this case, which was otherwise not treatable with usual CTO techniques. And you can even use it to perform aortic septostomy for chronic aortic dissection to facilitate transcatheter endovascular aortic repair in patients with chronic type B dissection. So to summarize, transcatheter electrosurgery can be used to traverse and cut different tissue types in a wide range of indications. And as you've seen, it enables very complex interventions in patients that are otherwise not eligible for conventional therapies. The required equipment and step-by-step guidance have been published for the majority of these procedures, and a lot of these you will see during today's sessions. Thank you very much for your attention.
Mohamed, that was a very nice overview of what we do these days with electrosurgery. But then the question is this also being adopted in busy clinical practices? And that brings me to Philipp. Philipp, you have a vast experience in transcatheter mitral therapies, among others. But in the TMVR space, are you using a lot of these techniques to maybe broaden the patient selection and the patient population that becomes eligible for TMVR? And what would be then your favorite electrosurgical technique? Is it Sesame? Is it the Lampoon? Is it the Batman procedure? How is that adopted in your practice?
Yeah, I'd like the comment of Mohamed to say that these procedures, they enable complex following procedures, but they themselves are complex procedures, obviously. And I think none of us, or very, very few, maybe it's different with Adam, but very, very few of us do it on a regular basis. Very few do it on a weekly basis. And the reason for that is, first, it is complex, but secondly, I think that while we started to do these procedures, we also understood a little bit better who is at risk for LVOT obstruction and who is at risk for coronary obstruction. At least in our practice, it seemed also with new devices that the necessity to perform these procedures went down a little bit, at least in our practice. But as said, they remain complex, and I guess if one can do them, if one would do them more and more often, then the incentive also would be greater, because it's still not routine, at least not in our daily practice.
Adam, what do you think about that? Do you see an increase or a decrease in your practice of these ancillary electrosurgery procedures?
Look, I agree with Philipp. I'll try and demystify some of these techniques in the next couple of sessions, but I understand the hesitancy to get started, particularly with off-label use of some of this equipment. But if you do it, I think you will find that maybe it's not quite as difficult as you think. Our practice has been pretty steady since we have sort of adopted it early, but I do see a lot of uptake of these over time. The centers that have started even on their own, or they've gone and learned from somebody else and then taken it. There are centers now that are more and more centers that are starting to do Sesame. So I think it is learnable, even with current techniques.
So, Giuseppe, how do you do that in your practice? Is there one super user where you like centralize the use of electrosurgery in the hands of one operator, or are all the structural interventionalists are learning these procedures and are also doing them? Oh, we don't hear you, Giuseppe.
Pardon, I think it's pretty much, being used to do CTO technique. You need to know, you need to know this kind of technique, because even though it is 2% of the cases, you need to know how to proceed with this kind of, electrosurgery technique, because otherwise the risk to have a real coronary occlusion is there, and you don't have any other option sometimes, because also with chimney sometimes it's not possible to get rid of the risk of acute coronary occlusion. So if I have to pick one, I prefer to go with a unicorn, to say something, and Batman, because I think that unicorn is much more simpler than Basilica. And actually we apply also now to tricuspidalize the bicuspid type 1, where there is a very severe calcifigraphy, and we need to go with a downsizing of the valve. We prefer to cut a side of the raphy with a unicorn. The puncture need to be mid-to-proximal, and then to go with the appropriate size, larger valve. So actually we apply also in this kind of subset.
Thank you. So Adam will do a deep dive in these advanced techniques like basilica, lampoon, and probably we will touch later on, and we'll get also a live case demonstration of these hybrid techniques where you combine electrosurgery with balloon techniques. So more on that. But let me first come with a tutorial on Transcaval TAVI and where to position Transcaval TAVI as alternative access. So if I can get my slides in front of me, that would be nice. So basically, I'm going to walk you through the principles of Transcaval TAVI, and then also what is the equipment that is required to do these procedures, and then compare Transcaval TAVI with transcarotid and axillary accesses. So I'm trying to, advance my, okay, here we are. So the principle of Transcaval TAVI is very important to understand. So basically, you work in the retroperitoneal space and you want to traverse from the caval vein, the inferior caval vein, into the aorta. The aorta is the highest pressure system. The caval vein is the lowest, and in between you have the retroperitoneal space. But it's important to realize that the pressure in the retroperitoneal space exceeds the pressure in the inferior caval vein. So if there is residual leakage from the aorta into the retroperitoneal space, it will drain immediately into the caval vein. So basically, you will not end up with a retroperitoneal hemorrhage, at least if you do not close off the caval vein. So I'm trying to advance my slide. So the principles of electrosurgery have been discussed already by Mohamed. I just want to emphasize again that the key is that you have to deliver continuous radio frequency energy in order to deliver heating above 100 degrees. And once you do that, once you achieve that, you will vaporize cells and you will cut through the tissue. If you do not reach those high temperatures, you will not reach your goal and you will not cut. Basically, if you do cauterization, then you use not continuous radio frequency, but interrupted radio frequency energy. And then you will heat the tissue, but not to these very high temperatures. And basically what you do then is you coagulate. Other thing to realize, if you need to do multiple attempts of cutting and you're failing, at one point you also carbonize the tissue. And that may again create isolation and insulation, and you will not be able to cut. So if you need multiple attempts to do this surgical cutting, then it's worthwhile to take out the wire and look for carbonization. And if you have identified that, you have to exchange to a different wire. So how to electrify a guide wire for transcaval access? Basically, you need proper insulation, and you scrape the coating at the end of the wire. You bring this wire into a microcatheter, for instance, a fine cross or a Corsair, and then you put that assembly into a Navicross. And then the concept of these three systems, so the Navicross, a fine cross, and then the Astato wire, that is being introduced in your 6 or 7 French guiding catheter. And then you connect all this to the pencil, to the electrosurgery pencil with the hemostat, and that can be then connected to the electrosurgery generator to deliver all the energy. So what do you have to avoid? Obviously, you don't want to have bowel in between the inferior caval vein and the aorta. You can check that by CT scanning, and some of the abdominal aortas are too sick for this technology. So if you have circular calcium along the abdominal aortic trajectory, then obviously there's no point in cutting. You won't be able to get through. But oftentimes you will find a sweet spot that allows you to enter from the inferior caval vein into the aorta. And there are some important principles and anatomical landmarks. So to begin with, you need to be at least 2 centimeters underneath the takeoff of the renal arteries. So and also you want to be at least 6 centimeters above the aortic bifurcation into the iliacs. The reason for that is if for whatever reason the closure phase is not successful, you will need a covered stent, and obviously you do not want to obstruct either branches of the iliacs or the renal arteries. So you have to take that those measures. So 2 centimeters, at least 2 centimeters underneath the renal arteries and 6 centimeters above the bifurcation. And you typically work in 2 fluoroscopic angles. So if you have a biplane room, that is the most easy way of proceeding. Otherwise, you have to take the discipline to work in a more or less AP view and then into a more left lateral view. The slides are not progressing, but in the next slide, I want to show you also that the upper margin of the crest corresponds to the intervertebral space between L4 and L5, and most of the time your target zone is at the level of the middle of L4 or the upper pole of L4. So we can go to the next slide. And how to determine this optimal X-ray projection? Basically, you can use CT scan, but sometimes you did not have the luxury of doing a CT scan. And what you do then is you bring in 2 pigtail catheters, one in the caval vein, the other one in the aorta, and you start in an AP view with the 2 pigtails in profile. And then you switch your projection into a left lateral view, close to 90 degrees. And then what you see is that more and more the curl of the pigtail becomes en face and becomes a bullseye. And that is exactly what you need to achieve. So you need a projection where you are cutting the pigtails in a profile and then in en face view. What are the toolbox for crossing? Well, you need the Astato wire, the Navicross, and the Fine Cross. I already mentioned that. You also need typically a renal double curve guiding catheter. And on the aortic, that is on the inferior caval vein side. On the aortic side, you need a gooseneck snare and a JR4 guiding catheter. So then we go to the toolbox for a closure. Typically, we close with an Amplatz duct occluder, an 8x10 Amplatz duct occluder, and you need to connect this occluder with a cable and a loader. And then you also use a small curl Agilis sheath. That is an important step, with also a bailout strategy with a long 014 balanced middleweight coronary wire. Now, you use the Amplatz duct occluder, and that's going to be shown in the next slide, to close the fistula that you created between the caval vein and the aorta. And you open up the disc in the aorta, and then you make a curve on the Agilis sheath, and then you pull the assembly all the way at the puncture site into the aorta, and that should, in principle, close the hole. It's always important to do a final angiogram. And as long as you have an angiogram that looks like the left-hand side or the funnel shape, then you are okay. So the funnel shape is important. That is the most common situation in my experience, where you see a residual shunting from the aorta into the caval vein, and that goes through the duct occluder. Now, if there is flow outside of the duct occluder, then that is a reason of concern, and that might be an argument for to do a tamponade with balloon occlusion, temporary balloon occlusion. Always do closures with protamine. So patients have been heparinized for the procedure. As you're doing the closure, you want to neutralize it with protamine. And what are your bailout strategies? Well, you can use balloon for tamponade purposes. Typically, those are sizing balloons, but sometimes you can also use, for instance, the balloon that you use for pre-dilatation or post-dilating of transcatheter aortic valves. And if you need covered stents, then you need Viaband stents for the smaller anatomies. For normal-sized or large-sized abdominal aortas, you will need the Bentley B-graft aortic stents. So CT planning, if you have the time to do an elective case, an elective transcaval case, you can do the CT planning. CT planning is you identify the sweet spot in the abdominal aorta, here typically seen at the middle of L3, and you look for a corresponding position in the inferior caval vein. And then on the right-hand side, you will do the rotation. You simulate the rotation that you could also do with the pigtails and the 2 dots, the dot in the inferior caval vein should be superimposed on the dot in the abdominal aorta. And by doing so, you obtain your 2 projections that will determine your working view for a transcaval procedure. Next slide, please. So this is how a transcaval puncture looks like. So on the left-hand side, you see a typical AP view where you have the gooseneck en face, in the profile, and then in the middle you see the bullseye with the gooseneck becoming the target where you need to aim the wire into your target. And then on the right-hand side, you see how you will advance then once you have snared the entire the wire and the Navi cross and the fine cross into the aorta. Now, the next slide shows you the final aortogram. So you see here that this is a funnel shaped, but there is a residual fistula between the aorta and the inferior caval vein through the device. So this is a very safe closure. This patient will do well, and there will be no issue of retroperitoneal bleeding. So if you compare that, and these are my final slides, with other alternative accesses, well, a transaxillary approach has the downside that, according to the literature, there is a slightly higher risk for stroke. And we also have seen that and documented that in a recent publication from the Thorax Center. The downside of transcaval relative to a transcarotid is that you will need a little bit more material for your closure. On the other hand, a transcarotid procedure is a little bit more time consuming and requires surgical access for the time being. So you see, if you balance all the strategies, the pro and cons, it makes very much sense to focus or to become an expert in at least one alternative access technology. But I think a transcaval approach is very attractive. It maybe is also the ultimate way to get started with electrosurgery techniques, because it's the basis of cutting. And as we will see later on, cutting can be then combined with balloon techniques, and then you have like a more hybrid strategy. But it's also very important, and this is also from experience, it is important to surround yourself with people you can trust when you want to embark in electrosurgery. Thank you for your attention. And maybe a brief question then to the panel. And then I would like to go to Mohamed. Mohamed, what is your preferred alternative access strategy now? Is it axillary? Is it transcarotid? Is it transcaval? What is it now in Leipzig?
Yeah, it's a good question. We kept on changing a little bit. I mean, you know, Leipzig traditionally was a strong transapical center as well, but of course, like everyone else, we stopped transapical a few years ago, and then we switched to transaxillary. You mentioned a couple of issues with transaxillary, including stroke, which I think is a limitation. And currently it's transcarotid, actually. So it's something that we've been exploring now maybe like for the last 2 or 3 years. And it's, of course, you mentioned that it's a surgical approach. It's not a purely percutaneous. And this is the beauty of transcaval, isn't it? It's a purely percutaneous approach. And like also from a setting perspective, you're just standing the way you are used to standing. And this is a major advantage. But we do transcaval, but it's not our second approach. So currently our main alternative access is transcarotid.
Okay, so in the interest of time, maybe we should ask Adam to proceed with his essentials of electrosurgery-assisted leaflet modification. Adam.
That's a great discussion. For us, transcaval, of course, is first. Mohamed did a great job illustrating everything that can be done once you're comfortable with the technique. So, but there is more unique applications than you would think if you look through the literature. And I agree that, of course, leaflet modification is the most popular. I get asked this question all the time, why I believe that electrosurgery is better than a mechanical cut. And here are some reasons why. One is you can do it with equipment that you're familiar with that is small. And technically, the blade is only exposed when you activate the button, right? So it's safe to move around until you're comfortable and then cut only for a short period of time. You are cutting rather than tearing because you are vaporizing the tissue. And of course, you could do it right now and relatively speaking, pretty cheap. You've seen these pictures before. The only thing I want to emphasize is that there is science behind the microcatheters and the bend in the wire. If you just concentrate on the bottom right figure, if you take a constant force, pull force, a constant time and a constant energy, and you just try that with a regular wire, and then you add in these things like denudation of the insulation, partial denudation, a microcatheter, you can see that sequentially you can get a farther distance, which tells you that you are concentrating the energy. And so that's why we talk about all of these subtle things that we do in terms of controlling the energy. And of course, there are two steps to leaflet modification. There is traversal, and then there is laceration, all centered around this concept called the flying V. So what I want to go through is what are the parts of the procedure where people seem to get stuck. So the first is how to make the flying V. So you've already traversed and snared the wire. You do not exteriorize the wire, you just lock it there. Now you have to back off the microcatheter to the end, but you don't have to take it all the way off unless you're doing other things like ballooning or unicorn. Lock it to the end of it, and then make the flying V directly in front of it. So here's what it looks like after a successful traversal. Again, you've snared the end of the wire and you've locked it into the guide. So now you back off your microcatheter. It could be a piggyback that it is in this example, or it could just be any of your microcatheters. There's about a hand width of wire left behind. I've locked that wire, or you would add a TUI on the end of it to lock it. And then directly in front of the microcatheter, you would scrape off the insulation with the sharp end of the blade. You would now flip to the blunt end of the blade. And then, of course, come under your towel and make your kink, being careful not to rotate the wire as you do that so that the denuded insulation is on the inner curve of the wire. The second part where people get stuck is now you have to do this push-pull to deliver the flying V to the tissue. So it's a little hard to get the bent wire through the TUI or your Y adapter, so you can unscrew it, pull it over the flying V. You can then push-pull until the flying V enters the guide and then reattach your TUI. You continue to do this push-pull. I like to add the introducer of the snare back over the snare so that I don't accidentally lose the wire as it's coming through the TUI. Some people don't do this. It depends on the brand of TUI that you use. And then, of course, position it across the leaflet and secure the talkers. So here's how this looks. There's the introducer of the snare being put back in so that when we do eventually pull the snare wire combination, the snare doesn't fall off inside the TUI. You can see your partner pushing. The TUI has been pulled off as we're pushing and pulling until the flying V goes in, and then it gets re-established. And then we continue to work as a team. You will see on the lower part of the image, eventually the snare and wire combination will come out. There has been an 035 torquer preloaded onto the microcatheter on the other microcatheter so that can be locked after the final positioning is created. Once the snare and wire comes through, if you're having trouble continuing to pull the wire, you need to pull it for another 20 centimeters or so. You can grab forceps, a Kelly clamp or something to just continue to pull. And eventually the flying V will be delivered to the tissue. So with this push-pull technique, you should be able to easily push the flying V to where it needs to. Once that has been accomplished, you can cut the bent end off of the wire, because now you can add two 014 sequential 014 talkers to that wire to secure that end of the system. So that 014 wire, what I refer to as the efferent limb, gets secured to the guide with two sequential talkers. If you look on the top of that image, you will see an 035 talker that will be pushed up against the guide to secure the microcatheter to the guide. And on the back end of that will be the TUI and an 014 talker. So here's the final setup. On the top of this screen, where the microcatheter is, at the end of the TUI, you will see an 035 talker that locks the relationship between the microcatheter and the guide. At the end of your microcatheter or piggyback, which is labeled F here, there's an 014 talker that locks the relationship between the microcatheter and the wire. And then, of course, the bovie is hooked up as shown by letter E. On the efferent limb, like I told you, that is the front end of the Estata wire that's been cut. So letter I shows two sequential 014 talkers locking the relationship between that guide and the wire. And then we have dextrose or saline flush syringes to also help with delivery of the energy to the tissue. So on the pull, we typically take out the slack in the guiding catheters before we supply any energy. We then cine so we can see what we're doing. I say infuse, so the person starts to inject with the two syringes. We say bovie on or burn, and then we pull and stop. It looks like here.
Yes.
And that's it. So troubleshooting. If you are having trouble traversing, make sure that you took the insulation off the back end of the guide wire that's hooked up to the bovie. Like Nicolas said, you could, after a couple of attempts, take out the wire and look and see if it's coated with char or carbonization. Have you short-circuited your system by any wet towels on the wire that's exposed? Make sure the generator is actually connected correctly, that the indifferent dispersal electrode is appropriately attached to the hip. Make sure your power is set to 50, that they set the cut mode to 50 or 30 or whatever you're using and not the coag. Sometimes the bovie pencil has a special insulation on it to minimize side injury when a surgeon is using it as a scalpel. But since we attach the wire to that flat part of the bovie pencil, if there is any green or clear coating on it, you can take that off to get to the bare metal. And if all of that is good and you're having trouble traversing, then maybe you're just hitting calcium and readjust your position to get through a calcium-free window. That are my tips and tricks on where I find people sort of get stuck in terms of adopting this technique.
Thank you very much, Adam. So we had some questions also from the audience. So what is the learning curve? What is a typical learning curve? How many cases do you need before you get comfortable with these techniques?
So I think that depends. It depends on your experience with using it for other things. Like if you've already done Transcaval and you've learned how to traverse, well, now your traversal is, that part of the procedure is already in your repertoire, and now you're just learning the second half of it. If you're starting with leaflet modification, then you're learning both at the same time, as well as the tips and tricks on how to get the catheter pointed back into the LVOT, for instance, for basilica. Well, so I would say somewhere between 5 and 10 cases is probably a good number of cases to get the repetition. And then I think as anybody moves on, your learning curve flattens out over time, and then you can try and concentrate on the finer points, of the subtleties of catheter manipulation.
Yeah. So somehow this flying. Sorry, Giuseppe, I had a question also for you. So somehow this flying V concept is, it takes a lot of maneuvers to get your flying V in place. But there are alternative ways now, right? We have the Batman, we have the unicorn, which combines cutting with balloon techniques. Giuseppe, in your practice, are people still doing the flying V, or are you guys moving directly to these more hybrid procedures?
Yeah, to be honest, in our institution, we started with Basilica, but now more and more, all the people of my team, they prefer to go for unicorn because it's simpler to say. But the point is that you need to be very thorough with the transverse to get through with the leaflets. So, and I have this question for Greenbaum. When you have a failure of the first and second attempt to getting through with the, appropriate insulation, you have appropriate electricity and all the things are there. In a wire, you can check the wire is not carbonized. What is the general mistake when we're not able to get through at the first or second attempt? Because actually, I have one answer to me is the thickening of the very degenerated leaflets. Sometimes it's very, very extremely difficult to get through.
Yeah. So the most common reason is sometimes that the operator is too basal and you're actually trying to burn through the sewing ring of a, for instance, a surgical valve. And that's one mistake. The other is, you're correct. The second most common is that if there is confluent calcium or a big ball of calcium at the base of the leaflet, that is very difficult to traverse. If it is just a thick leaflet, it may be just that you maybe need a tiny bit more energy. So sometimes going from the 20 to the 40 gram tip estato can be helpful as long as you're comfortable that you're pointed back to the LVOT. You can actually infuse saline or dextrose during that step. We typically don't, but if I'm struggling, I may add it for that. So those are two tips. But ultimately, it may be that you just need to move to an area where there's no calcium. There may be just one ball of calcium that you seem to be right on. If the entire leaflet, if you look on your CT on the base of the leaflet, from commissure to commissure is confluent calcium, those are not great cases for this technique.
And what about the amount of energy that you deliver? Are there some grades to that, or do you give 50 watts for everything, for every procedure, or do you sometimes go to 70, to 90? What is the wisdom there?
So I think the energy that you set is somewhat dependent on actually the Bovie unit that you use, the energy unit. For the most part, for leaflet traversal, we're around 50, and for laceration, we're around 70. But if you are very good with your insulation and it's a pretty soft leaflet, meaning maybe you're doing it because it's a long leaflet, but it's not calcified, you could probably go down to 40 or 30 on the traversal, and you might be able to go down to 50 on the laceration. So I would say 30 to 50 is a reasonable range for traversal, and 50 to 70 for laceration. I think that if you're just cutting a leaflet, I mean, look, with unicorn, you're basically obliterating the leaflet. So higher energy is probably not bad for leaflet laceration. Sesame may be a little bit different because we're in a tight space because we're intramyocardial, but for basically cutting a leaflet, I think more energy is not harmful. So I use 50 and 70.
Yeah, and so I typically use, for my Transcaval cases, I use this assembly of an Astato wire with a fine cross and then a Navi cross. How important is the Navi cross in your opinion? Or is this something that you can leave out if you do leaflet laceration?
So we don't use a Navicross for leaflet laceration. The reason we use the Navicross or an 035 microcatheter in generic terms for Transcaval is so that you can take the inside, the wire and the 0.4 microcatheter out and get to your 035 stiff wire to put your sheath in. And it doesn't need to be a Navicross. It could be whatever flavor of 035 microcatheter that you like. I happen to like the braided microcatheters because I can twist them and they help get through. You know, you did show some pictures of some pretty bad aortas. So if you're trying to get through a thick wall, I think a braided microcatheter may be a little bit better, but the Navicross is not the only one. There's a barred seeker. There's an 035 quick cross, which is not braided. And there are many, many others. So most important thing is this telescoping system in lengths. It's a 300 centimeter wire, right? It's a 130 or a 150 0.14 microcatheter. And then it's a 90 centimeter 035 microcatheter. So as long as you have this telescopic system in length, they almost all will work.
Yeah. So Mohamed, is it what is your practice these days? Still using flying V's, or have you moved on to balloon-assisted electrosurgery techniques?
Yeah, so most of the time still using flying V's, to be honest. Like sometimes augmenting this with a small balloon, like balloon augmented, but still like lacerating leaflets rather than obliterating them. I mean, there are a couple of reasons maybe for that, at least in our practice. Maybe the first reason is we feel comfortable with leaflet laceration, probably because we did it so many times. So this is probably one hurdle that we don't have. The second thing is, I think, at least the experience we have and the literature that has been published by many groups, of course, also by Adam and the group in the United States, is extremely solid. So I don't think we have this yet for the other techniques. And I would say the third and main thing for me personally is that if you want to do unicorn, the classic one, you're probably committed to a balloon expandable valve to do the intraleaflet deployment, because otherwise you will have to lacerate the leaflet completely in an unpredictable way. And usually these patients that we treat, they are usually small surgical valves, where we tend to prefer self-expanding devices for hemodynamic purposes. And probably this is, at least in my practice, the main reason to prefer leaflet laceration.
So you and the audience definitely need to stay tuned, because the folks here in Bordeaux are planning to do a live case, a TAV in TAV, in a failing evolute, where they are planning to do a unicorn with then another evolute. So let's see how that will pan out live. We have multiple questions from the audience. They're very active. One of the interesting questions is, how do you confirm that leaflet modification has been successful before you do the actual valve deployment? Philipp, do you wanna take that one? So how do you confirm that you're happy with your leaflet modification?
On echo is very important for these procedures, at least when it's on the mitral valve. The question is a very important one, because it's not that certain that you always make it with a perfect cut. You have to ensure that you achieve what you wanted to achieve. And for me, I rely here mainly on echo, or solely on echo almost.
So do you get additional information from the way you did the laceration, Adam, or the way that the balloon is being deployed in the leaflets, if you're using a balloon for that matter? How do you interpret that?
I think if you are pulling and you're pulling harder than you think you should have to, I think that is one feedback that you get, that you may have an energy problem. Maybe the fine cross has come over the leaflet and you're trying to pull with plastic, and maybe the flying V is not on the leaflet. So I think if you're having to pull more than 1-2 pounds of force, I think you should stop, reassess everything, and then try again rather than pull harder, because it's the tactile feedback. If it takes a hard pull, you may have torn the leaflet off a commissure or avulsed it, and then I think it would be important to look by echo to see if that has occurred, as opposed to a cut in the middle.
It depends also.
Another question is, go ahead, Giuseppe, go ahead.
No, it depends also on the leaflets, because sometimes you get through with through the leaflets, but actually with the energy you need to pull, it doesn't happen by its own. It depends on how thick the leaflets and calcified the leaflets. So I don't think one size fits all, to be honest. This is one of the reasons why the V technique, the V flying technique, when you start doing electrosurgery and leaflet modification, is the reason why I think that unicorn or balloon-assisted procedure are a little bit easier, and the operators are a little bit more confident to do that because it's a little bit straightforward.
How are you going to do, Cesar?
Another question. And another important question from the audience, and that has been asked by multiple folks out there. What safety protocols are non-negotiable before any electrosurgery assisted structural case begins? And I would let me add to that. Do you need a surgical team ready to go if you do these procedures? Adam, what do you think?
Well, that's an interesting question. I never really thought about it, but I mean, don't we have a surgical team ready to go already for any structural procedure that we do? And I guess that would depend on the patient risk profile, right? There are certain patients that we've made a decision before we do the procedure that we're not opening this patient, regardless of the outcome, and there are others that we will. I think that you would need to be able to handle complications of the electrosurgical approach that are specific to that. For instance, if you have an errant burn during basilica and you cause damage to the anterior leaflet of the mitral valve, a hole in the anterior leaflet of the mitral valve, if you get a hole in the sinus, the aortic sinus, and now you have a sinus to LA fistula, for instance, or if you had an aortic wall hematoma. I mean, these are really rare complications, but they have occurred. I think you should be able to fix them, in the patient with the right risk profile. Now,
Philipp, so Philipp, that's my question to you. Do you have a surgical team ready to go for some of the dramatic complications that may occur if you do lacerations or modifications of mitral valves or aortic leaflets?
Yeah, we do, because we normally do those procedures to enable procedures where we need surgical backup anyway, and also where requirements are that these procedures are only performed when you have surgical backup at the center. The question is whether you could also do without, and it's a little bit the same with Adam. I've never asked myself the question because I do have the luxury of surgical backup. I think given the overall complexity, not only with these procedures, but also with the following procedures, I think it's wise to do these procedures at centers where you have surgical backup. But it's not that an OR needs to stand still and wait for these procedures to be finalized. I don't think that's the case.
Well, I like to add to that if you want to be doing structural interventions in a hybrid room, probably these are the kind of procedures that you would like to program in those hybrid rooms, because then obviously you have already the surgical environment where surgeries can come in and start a life-saving procedure if required. Maybe then a last question before we move on to the next session, and that is that the FDA has cleared the Telltale technology, Adam. But what is the status there? Is this technology that will be commercially available anytime soon in the US? And if so, are there plans to also go outside of the US?
I don't know those answers 100%. But I believe there is plans for a commercialization, a commercial launch in the U.S. and then potentially outside the U.S. But you would have to ask Transmural Systems that for a more clear answer.
Yeah, but I think the important word that you used is a soft commercialization, and that means that it will be restricted to selected centers. And to be honest, I'm a little bit afraid that we will not see that dedicated technology for electrosurgery anytime soon in Europe or outside of the US for that matter. So I do believe that for those of you who want to embark in these electrosurgery techniques, and don't get me wrong, these are very compelling and very important new technologies that really are ancillaries for TMVR and also revalving procedures in a significant number of patients. And I also agree that we are now already exploring expanding indications of electrosurgery. The one, for instance, that Giuseppe already mentioned, the treatment of patients with bicuspid aortic valves to tricuspidalize these valves, which would make then valve expansion easier to do, is a very interesting one and has been explored by multiple sites. So I think we are definitely in a good place in terms of electrosurgery. I think a lot of the procedures can no longer be or should not be done without at least the consideration of electrosurgery techniques. And I think it's fair to say that if you are involved with TMVR, for instance, that screen failure rates are still relatively high, or more than 70%. But once you start to also apply these electrosurgery techniques like sesame, or you do leaflet modification, then probably more patients will become eligible for TMVR technologies. And we have to face the fact that there is a significant set of patients who have so many comorbidities that they're just now no attractive candidates for open heart surgery. And that doesn't mean that surgeons could not be available for bailout strategies if needed. And at the same time, it's also wise to have cardiac surgeons involved in your structural heart program. So I think if you do these cases, if you do elective electrosurgery cases, it is definitely wise to have your surgical team aware that you're doing the case, and that they are aware when complications may occur, and that they are ready to go to help you out if required. So with that, I think we are right on top of the hour. We are at the end of this session, and it is my great pleasure to move on to the next session, and that will be more of Adam Greenbaum and electrosurgery.